are actually going to encounter two parts between now and lunchtime. So just to manage expectations, I'm introducing part 2 now. And the goal of this section is to describe system-wide challenges. And can we have, yeah, here come the slides. So we should be on 24, I think. The goal of this section is to describe system-wide challenges that are frequently cited as causes for concern, both from a broad public policy perspective, as well as from the more focused but extremely important perspectives of consumers, healthcare providers, payers, and/or purchasers. As we move through these topics in subsequent slides, I'll often try to start from the system-wide perspective or public policy perspective, but then I'll try to point out how and to what extent these issues affect CalPERS and its members. And after we talk about these problems, we sort of take stock of the problems. The third part, after opportunity for questions, will be around the levers and influencers who can affect these problems. So next slide, please. I mentioned at the outset that healthcare costs have long risen at rates that exceed other areas of the economy. This means that healthcare takes up growing shares of public budgets. It causes employers to have to spend more and more on coverage instead of on wages or on other investments. And to the extent that those costs are passed on to consumers in premiums or cost sharing, it puts direct pressure on household budgets as well. That spending pressure might be partly justified if there were a clear link between higher spending and better access to care or quality, but that's not the case, as you'll see when we move through subsequent slides. Another thing that higher costs don't correlate to, and this echoes back to one of the questions and discussions we just had, prices hospitals command do not correlate directly with how much care they're delivering to public program enrollees. So even though there is some of that cost shift, the cost shift is not what differentiates the 100% of Medicare versus the 450% of Medicare, as Marta indicated. Instead, hospitals with lower shares of Medicaid and Medicare patients are just as likely to charge very high ratios of Medicare reimbursement as those with higher shares, as this nest of data shows you. There is no linear correlation. Next slide, please. Instead, and I believe you've heard about this in previous presentations by outside experts as well as by your internal CalPERS leaders, costs and premiums are linked to market concentration. So this slide is taken from research by Richard Scheffler and colleagues at UC Berkeley and shows that 3 different measures of market concentration: high market concentration or lack of competition among hospitals, which is the longer green line, market concentration among health plans and insurers, which is the blue line, and vertical integration between hospitals and physician groups, the gray line, all are associated with higher premiums. So it's not, the trend upward means the more concentration, less competition, the higher the premiums that plans are able to charge. Next slide, please. It's also the case that not all healthcare spending is created equal. Many analyses have demonstrated ways in which the US healthcare system supports or allows spending that is of low or dubious value or worth. This slide offers several categories of healthcare spending that could and perhaps should be reduced in a well-organized system of care. In our system today, there can be incentives for overtreatment. I know you all have looked into this in, for example, the Smart Care California initiative, and there's a federal program, the Choosing Wisely initiative, where rather than responding to incentives for overtreatment on things like back imaging or even surgery for pain that might very well resolve on its own without those interventions, the idea would be to avoid that and instead rely on watchful waiting or more conservative care. Failures of care delivery and inadequate prevention, this category involves cases where earlier intervention could reduce the need for costlier treatment or Better management of chronic conditions might prevent expensive hospitalizations. Poor coordination of care involves people receiving duplicate services or care from multiple providers and settings in ways that can potentially compromise outcomes, as well as increase costs. Administrative complexity is certainly a feature of many aspects of our healthcare system. It contributes to costs without commensurate increase in value. These are things like the contractual and billing burdens that healthcare providers bear, the paperwork and enrollment hassles that consumers face, and these arise in a fragmented multi-payer healthcare system such as ours. I already mentioned the issue of consolidation and monopoly pricing, which increase spending without generating a lot of value to patients or society as a whole. And then finally, outright fraud and abuse also does occur. Providers might, in some cases, bill for services that weren't delivered. There can be pay-to-play type schemes or steering by certain kinds of drug manufacturers or specialty providers. And clearly, these contribute to costs. However, exactly how much of today's spending is excessive is very difficult to accurately estimate and maybe even harder to address. Providers and patients alike sometimes tend to think that more is better, that on the balance, they want to be careful. They want to have additional tests or services just to rule out any problems or to be sure they've done the most they can. Some administrative overhead and coordination costs are the price we pay for additional choice so that consumers have an array of health plans and providers they can choose among. And in some aspects, that choice increases patient and provider satisfaction. So at least for the first 5 items on this list, some of the waste, it can be argued, is really in the eye of the beholder. Next slide, please. So above, I focused on some of the forces that drive spending associated with care in the delivery system once care is already underway. But I also want to note that broader factors cause healthcare spending to rise at rates that are greater than those of the overall economy. In particular, when the population ages, people have greater healthcare needs, and the costs of interventions that are very much needed and fully appropriate increases along with that. So everything else equal, year to year, there will be an increase in healthcare spending just because our population overall is getting a little bit older. And of course, when new treatments emerge, greater investment in them follows, and they should bring along with them reduced disease burden or improved quality of life. So there are things that drive that aggregate spending that are unavoidable and perhaps one would not wish to avoid them because they actually bring value or important care. Next slide, please. Moving now to the quality of care. So that was just a couple of observations about aggregate cost. On quality of care, the quality of care that Californians receive is variable and is not correlated directly with cost. So a word about how to look at quality. There are many measures of clinical quality that are available to assess care for a particular population. For example, disease and age-specific measures to assess whether people are receiving proven care and to compare the clinical outcomes that they experience. This chart from the Integrated Healthcare Association shows that clinical quality of care for Californians enrolled in private or commercial coverage, which would include CalPERS as well as other employer sponsors, varies greatly. The horizontal line in the middle reflects average composite quality across the state. So that's the average right in the middle, with care is left to right. So lower cost on the left, higher on the right. So the upper left quadrant includes coverage products that are higher quality and lower cost, the things you might want the most of. And the lower quadrant shows products that are not only lower quality, but also higher cost. So there are plenty of products available in all of these quadrants. And there's no clear correlation between cost and quality, although there is an indication that participation in HMOs or other managed care arrangements yields better quality on a population basis. Next slide, please. Quality varies over other important dimensions too. In particular, there is reason to be concerned across many domains of the healthcare system and health outcomes that race is correlated with quality of care. One measure of quality is the likelihood that people will be readmitted within 30 days following a hospitalization. As you see here, the rate for Black, Native American, and Latino Californians is higher than that for Asian Pacific Islander Californians and white Californians. This is but one of many, many examples of disparities that come along with race. Mortality, life expectancy, as well as maternity outcomes are two more examples that I know you have doubtless encountered data about. There's ample reason for concern that the forces of structural racism, as well as coverage, access, and affordability concerns, lead to systematically poorer outcomes for people of color in California. Next slide, please. There's also regional variation in the quality of care. Preventable hospitalizations are one illustrative indicator. Darker counties have higher rates of preventable hospitalizations. And as you can see, many of those counties in darker colors with worse performance are in the Central Valley, in the Inland Empire, or in the rural North. Many factors contribute to disparate outcomes by geography, including issues of accessibility, provider shortages, which we talked a little bit about earlier, and again, there are racial and socioeconomic overlays in terms of who has what kinds of coverage, who faces what kinds of barriers. Next slide, please. So to summarize with respect to quality, certainly purchasers and those concerned with system outcomes want to pay attention, not just to what we're paying for in terms of healthcare, but to the quality of the services that are being delivered and the patient outcomes that result. But there are a number of complexities associated with both measuring and then improving quality, as outlined here. So first, in terms of defining and measuring quality, people care about clinical outcomes, those things you can measure, like did you get your regular diabetes testing and are your blood sugars where they ought to be? But they're also concerned with their patient experience. Was I treated with respect? Could I get an appointment in an easy way, and so on? So that's important to consumers, and it's important to pay attention to. It can sometimes be difficult to know how to balance that against the clinical indicators in assessing the value of a plan or a provider group. In addition, individuals may have different preferences about their care, sometimes for reasons that are not directly linked to clinical quality. Again, my peace of mind might make me want to have that extra test, have that back image, or even if it's not likely to make a lot of difference in the trajectory of my condition. So those two factors, should you factor in consumer experience in any way, shape, or form? And how do you think about what's clinically right for a whole population versus what is preferred and desired by individuals? Even once you decide what should be measured, it can be very difficult to collect and report data in appropriate ways. So for example, if you think you want to measure what's going on at a provider group level, you still have problems of small patient populations or small groups of people with a particular condition or need that can limit your ability to know just what's going on in terms of quality. Then, once you figure out how to define and measure quality, there can be challenges around rewarding and improving quality. So in terms of rewarding quality, again, in this fragmented system, who is it that you hold accountable? How do you reward or penalize them? What incentives can you put in place to help improve, to move the dial in terms of the outcomes that you care about? And importantly, what's the relationship among health plans, medical groups, and other participants, and the care team, the direct care team, that can put those changes in place. So again, payers want to hold plans accountable. Plans want to engage providers in quality outcomes, but sometimes where these decisions and the difference in terms of quality gets made is really one-on-one in a provider's office and is hard to aggregate and address at the system level. Next slide, please. Moving on now to the third challenge on our list after we talked about cost and quality, access to care. So there's broad agreement that this is an important goal. And for example, in California's regulatory framework, health plans are accountable to provide timely access to services. Nevertheless, the on-the-ground realities can make it challenging to assure that everybody has appropriate and equitable access. As we've already discussed, healthcare providers are not evenly distributed around the state. That can be a factor. People may live very far from the types of providers that they need. On a per capita basis, there are more primary care and specialty care providers in the Bay Area and Sacramento than in most other parts of the state. And there are provider shortages as measured compared to national standards in the Inland Empire, in San Joaquin Valley, and in the rural north. Language and cultural competence is also a concern in terms of access. People of color are significantly underrepresented among physicians, and 7 million Californians, the majority of them Latino, Black, and Native American, live in areas that are designated by the federal government as healthcare professional shortage areas. So unless there's substantial investment in cultivating the healthcare workforce of the future, and that is not something, again, that an individual purchaser can do, but perhaps statewide or through partnerships that can be encouraged, those shortages are likely to increase with the retirement of aging healthcare providers. Access to specialty services is also a concern, particularly for some specialties and for some payers. For example, fewer than half of California's psychiatrists see Medi-Cal patients. Delayed or foregone care can result. Now, compared to enrollees in public programs, CalPERS members have fewer access challenges because CalPERS plans have generally robust networks and provide higher reimbursement levels, as we've previously talked about, than public programs. But you're not completely insulated from the challenges that result from workforce distribution issues, from these geographic issues and these issues of cultural competence and language. Next slide, please. There is, of course, an intersection between access to care concerns and out-of-pocket costs. Now, this is not a particular issue for CalPERS because your benefits are comprehensive and cost sharing is low. But as this chart shows, more than half of Californians have experienced one of the access challenges listed here, including delaying or skipping medical, dental, or psychiatric treatment, not filling a prescription, or skimping on prescribed medicines. So this underlines the idea that system-wide efforts to grapple system-wide efforts for improvement have to grapple with these interrelated challenges of access, consumer affordability, and system cost. Next slide. You may be aware of this, but concerns around access to needed care have worsened in the pandemic era. A survey from a few months ago shows that nearly a third of Californians say they did without needed urgent or emergency care, and closer to half said they went without care for less urgent and mental health concerns. So this is no doubt linked to stay-at-home guidance and reduced in-person services available in some care settings. But there may also be an economic overlay. So as economic anxieties have increased, as people have had less disposable income, perhaps, that may have been a factor as well. So again, this is less worrisome for CalPERS members than for other Californians, but it is a system-wide challenge. Next slide, please. The fourth challenge on the list involves disparities by race and ethnicity in both health access and health outcomes. Again, there are so many different ways to measure this and so many different indicators that I might have cited. Here, I'm taking just the very aggregate measure of self-reported health status, which is obviously influenced by many, many different issues. But more Latino and Black Californians report poor or fair health status than Californians who are white or of Asian descent, as shown here. Next slide. So COVID-19 has, as has been widely publicized, had disparate impact by race and by ethnicity. This is data that now, sadly, is out of date. There has been much more morbidity and mortality in the month since I pulled this data down, but the trends continue in the same ways. Notably, the top line here shows that Latinos, while they represent about 39% of California's population, have at this point comprised about 48% of deaths due to COVID-19 and 56% of cases. And again, there are many overlays with socioeconomic factors, but again, a worrisome indicator of discrepancies right now. And in the case of African Americans, while at least at this point they were a little bit underrepresented in cases, they were sadly overrepresented in the number of deaths due to COVID-19. Next slide, please. So what leads to these inequitable outcomes? I've already mentioned the socioeconomic factors, and in the case of COVID-19, the types of jobs and living conditions that people have factor into it. But I wanted to talk briefly about the system factors that lead to inequitable outcomes. And this derives from some qualitative research done by the California Pan-Ethnic Health Network. They wanted to really dive into how system factors contribute to inequitable outcomes. They interviewed Californians of diverse identities and backgrounds, including race, ethnicity, disability status, sexual orientation, and gender identity. And they uncovered a number of problems that contribute to these inequitable outcomes. For CalPERS's purpose, I think the important thing to keep in mind that comprehensive coverage such as you offer may alleviate the affordability concerns and maybe even the sources of complexity that come along with some aspects of the healthcare system and coverage. But some of these other issues, the challenges around stigmatizing or disrespectful treatment by healthcare providers, the lack of poor patient engagement, by which I mean not listening to people who don't look like you or who, for whatever reason, don't command the attention of the healthcare system the way that their more privileged counterparts do. Those can be a problem for marginalized groups, even if they are CalPERS members and have the benefits that you all assure. Next slide, please. We've now arrived at the fifth and final challenge that I listed, although questions and commenters might well come up with other challenges in our complex system. The final factor that gets in the way of an efficient and affordable healthcare system, as well as equitable outcomes, is it involves the array of contributors to health that are above and beyond the healthcare system. So when we look at the broad array of factors that contribute to longevity, to health and quality of life, the investments we make in healthcare services determine only a fraction of the variation in outcomes. According to one analysis, about 20% of the variation in health outcomes can be attributed to differences in healthcare access and the quality of care. Everything else, all the other variation, stems from differences, these factors other than healthcare, factors better addressed by human services, sometimes called upstream investments in health. So, for example, 40% of the variation can be attributed to socioeconomic factors, education, employment, income, as listed here. Then there are physical environment issues, as colleagues at the California Endowment say, where people live, work, and play, and the safety and opportunities available in those locations. And then health behaviors are a factor, including tobacco and alcohol use, diet, and exercise. But of course, those intersect with some of those physical environment and socioeconomic factors as well. So when one thinks big picture about improving health in our country or in our state, these social determinants really need to be factored into the equation as well. Next slide, please. This data from the Commonwealth Fund compares spending on healthcare, the dark blue, and social care, turquoise, for 10 economically developed countries, as well as the US. The US spends 17% of its gross domestic product, its overall economy, on healthcare, which is a larger share than any of the comparison countries. The US spends an additional 17% on social care, which totals 34% across the two sectors. Most other comparison countries invest less in healthcare and considerably more, particularly as a proportion of the total, on social care. Next slide, please. So to summarize, and then we'll have an opportunity for questions on some of these problems and challenges, our healthcare system is, as I described in part one, a patchwork of delivery and financing approaches that has evolved in response to market incentives and regulatory requirements, but without any unifying vision or set of mechanisms to keep collective goals at the forefront. From a big picture viewpoint, it falls short with respect to cost, access, quality, and equity outcomes, partly because we focus so many resources on health care rather than the broader social context that influences health status. Since so many different actors interact in different ways in our patchwork system, the next section will tease apart different influencers and types of influence that they exercise. But first, I welcome any questions about what some of these problems and issues are.
Mr. Rubalcaba?
Thank you, Mr. Jones. It was an excellent presentation. Thank you. I appreciate this part because it talks about the challenges. I did have a question on the discussion about quality on the chart on page 29. I noticed that you differentiate between whether members were in or not in a ACO, an affordable care organization, and I noticed that, and also I noticed that HMOs and the ACOs tended to be higher quality, but they were all over the place in cost, and so that seems to run counter to the whole thing about integration that you talked about in part one, where the growth of cost tends to be less when there's integration. And yet also when you promote all this, I know you won't talk about plan design or networks until the next part, but there's also the whole, you introduce it here about the whole thing about ACOs and I know you're going to talk, the whole, it brings to mind the whole thing about our ACOs really working, the whole thing about narrow networks, because you were also talking about access and you had the geography, geographical barriers, but within geography, there's also geography barriers. Because I'm thinking in where I live, there's no narrow networks within area, and the facilities tend to be older plants. So I bet you that's one other reason that would impact the readmissions and the quality of care and all that kind of stuff. So I was wondering if you could speak. I know I rambled on a little bit, but if you could speak to the this chart and the ACO and why, how you differentiate between HMOs with and without ACO and all that.
Yeah, thank you so much, Mr. Rubalcaba, because you raised an issue that I should have made clear and did not. So first, I also want to disclose that I found a much simpler and cleaner version of this chart while I was preparing my remarks that I wish I had put in the document rather than this fairly complex one. But the question that you raised first that I will address is around this question of clinical coordination versus economic consolidation. So what we see here and in many other aspects is that clinical coordination, which can be achieved through HMO arrangements in some cases. It is the goal of ACO, accountable care organizations, to have providers responsible for the total care of an entire population. That does yield benefits in terms of quality. It is more uneven in terms of cost, and that's because some of the market forces that we talked about allow it to be uneven in terms of cost. What's clear in terms of cost is that if you have a lot of economic power and you can wield that power, you can leverage higher payments, and that is a separate issue, which is not really reflected on this chart. It is uncovered through other types of research. So that's one issue. You know, I am not. I might defer to Marta or to Dawn to talk about the specific benefits and knowledge to date about ACOs, particularly in the CalPERS context. But that would be the umbrella comment that I'd offer.
Yeah.
Oh, go ahead, Marta.
Yeah, I would just say that our information is similar, that the HMO ACO integrated arrangements have greater clinical outcomes, but do not necessarily show across the board better cost outcomes. That is really driven by the regional market forces, as Marian describes. So her larger points are absolutely what we see in the CalPERS data.
Thank you, both of you. Appreciate it.
Thank you. Ms. Oliveris?
Thank you. Ms. Mulkey, can you please go to slide 39? I was surprised to see that physical environment contributed only to 10% of health outcomes. And does that include disparities, for example, due to particulate matter or, you know, poor air quality?
You know, I will confess again that the point of this slide was more to give a broad brush sense that healthcare is, you know, by the time you get to the clinical delivery of healthcare, you have limited ability to influence outcomes. The physical environment, I think that is really intended to be more around the living situations, and I honestly am not sure. I did not go to as far into the primary data on this to know for sure about the environmental conditions that you're talking about. Those are for sure a significant factor. You know, in this kind of analysis, it can be very hard to tease apart issues around income, socioeconomic status, living location, geography as well. So I will say that I don't know for sure the answer to that. And you may be right that if you factored it a different way, some of those environmental conditions and locations may have an even bigger influence.
Thank you. And then to what extent do demographics align with this? So for example, race, ethnicity, gender.
Yes, I mean, I think that in complex ways is the way I would answer. Education, employment, income, community safety, sadly, are not evenly distributed by race and ethnicity. In some subsets, gender as well. And so I think to the extent that we overinvest in healthcare and, you know, invest in complex and heroic interventions for people once they get sick, and miss the opportunity to invest in early education and social supports that allow children and families to meet their greatest potential, those are, I think, inherently biased. Exactly to what extent, I couldn't say, but that I think is a significant concern.
So then is the message that equity is tied to positive healthcare outcomes?
Yes, I mean, thank you for reframing it. This section, I sort of described the problems as inequity leads to worse outcomes. So but you're right. Yes, I think I think there's ample reason to think that if we could deliver more robust social services and deliver healthcare in a more equitable way, then we would close some of those gaps around mortality and access to care and affordability that we were talking about as being symptoms of a problem.
Yeah,
Thank you. I think that helps frame the context for it.
Thank you. Yes, I appreciate the comment.
I would just add that there's evidence in that when you look at some of the spending ratios in the countries that Marion clipped through. So, we lag all of those countries in life expectancy, incidence of chronic disease, infant mortality, and we are spending more on healthcare, considerably more on healthcare, comparatively less on social support. So there is a correlation when you look at wealthy nations and what they spend in those categories with better health.
Got it. Thank you.
Okay, Ms. Taylor.
Yes, thank you. I just wanted to thank you. These presentations are very informative and really good and easy to understand. So I'm back on the lack of investment in social determinants of health. And I think it sort of piggybacks on Ms. Oliveris's question. So do you have any idea what the difference, what are we not spending in the social care venue that would help us improve our outcomes?
Oh, oh my goodness. Don may want to speak to this as well, but everything from, early child care services and supports to, caregiver supports for people with a disabled family member or an elder who's also in their household. Job training. Just so many things that that, as Don indicates, comparison countries invest in as a matter of course. Unemployment supports for people in transition positions might, in some categories, count as these kinds of social supports. And again, some of it is very direct, tangible economic investment in households that might otherwise be low income or detached from social services. Some of it is peace of mind and mental health stabilizing as well, because if you're a mom with 2 young kids and you have to work 60 hours a week as well as manage other things, there can be spillover effects in terms of your health and mental health and that of your children, I believe.
So I appreciate that. That's also lends into the disparity, because if your living situation is precarious or you don't have access to healthcare a lot of times, and I think that's where I know we don't, but we have to focus as a nation on providing these services that will help the outcomes, because it helps everybody in general. So, but I appreciate that. Thank you.
Thank you.
Okay, Ms. Middleton.
Thank you, Ms. Mulkey. This has been really illuminating. I want to ask what I think is going to be a very difficult question, but the COVID-19 pandemic has cost us right now close to 400,000 lives. And the projections are very shortly it'll approach 500,000 lives lost in the country. That's a damning indictment of the American healthcare system as we administer it today. And I'd like to get your sense of what you think will be the changes in the American healthcare system as a result of this pandemic experience, and to what extent it will change some of the attitudes towards our healthcare system.
Well, thank you for raising that question. And I wish I knew, and I wish I could assure that it would be positive, that the implications would be positive and sweeping. I'm not sure that I do. I think there are a couple of very, very big challenges that I have not seen a lot of traction toward addressing. One is investment in public health, that is thinking about community health needs as opposed to individual or even covered population needs. The contact tracing, the public information, all those issues that we have been disinvesting in for decades and were not prepared to really mount a quick, coordinated, equitable approach coming back. Will we, after this is over, invest more in that and integrate it better with the delivery of healthcare services? I certainly hope so. I just don't know. The other thing, though, that this really illustrates is the fragmentation of care delivery and the disparities and uncoordination of people's connections to any healthcare system at all. So, when you think about distributing the vaccine, if everybody in the country had a medical record number and had a primary healthcare provider, and those were all linked in an IT system where you knew where everybody was, you would have a different distributional challenge than you have today. And I think there may be some opportunities to build on some of the small and positive changes that have come with COVID-19, the greater use of telehealth, the greater integration of services across multiple needs. So I think there are some opportunities, but the sweeping top-down changes, I don't know, and I'm sure. I'll stop there, except to say the political context is part of the issue about how we invest in this and how we position it. I have a point I'll make later on about sort of individual responsibility and a sense of community accountability and responsibility. And I think that is a huge factor right now in COVID-19, as well as in just about everything about our shared life.
Thank you. That's very helpful. We know industries all over the country are looking anew at the way they operate because of what we've experienced in the last year. This is editorial comment, but it's incumbent on all of us when it comes to healthcare to truly step back and assess what we've done right and wrong.
Hey, are there any other questions? Yeah, I have one. We talked about the disparity and the differences in social economics, and one of the common themes through all of those issues has been race. And so has there been any thoughts given to incentivizing doctors to, number one, go to areas that may be more difficult to staff doctors? Or I know that in my other life, we had hard to staff schools, and we created an incentive plan for teachers to go into those hard to staff schools, and it helped solve the problem. So has there been any thought of incentivizing physicians and healthcare providers to go into these areas to deal with these systemic problems?
Yes, there have, and there are some federal programs that make financial support available to healthcare providers in those federally designated underserved areas. There were recommendations in the California Future of Healthcare report that involved investing in providers that particularly meet that address the biggest gaps, including those around racial and socioeconomic issues. But it takes investment and it takes intentionality. And I think that those have, I think we are at a point with respect to the provider situation where the problem is going to keep getting worse in visible ways until there is a more significant investment and level of attention to it.
Yeah, I think that point is right on, because the initial program that I'm referring to, the first allocation for the incentive was too low. It didn't attract enough people. And then as it raised, it began to attract a sufficient number of people.
Yeah.
So I think that's right on.
If I could add,
Okay.
there's some a few small programs in California. So some of the federal monies are administered by our colleagues at the Office of Statewide Health Planning and Development, and they have some state seed money that's offered through the state budget process. When my former department would oversee a major health plan merger, they would negotiate, basically donations to those programs in order to expand physician loan repayment programs and the like. Similarly, some of our Medi-Cal managed care plans that are locally based are those that see the greatest physician shortage. And they actually, some of the more robust and forward-thinking ones actually have their own physician shortage programs where they will do loan repayment programs for those that agree to serve patients in their local community, especially those that are multilingual and can provide clinically appropriate and patient appropriate care in those settings. So there's lots of little stuff happening, but I think to Marion's larger point, there isn't kind of a global approach that's completely coordinated. It's a very fragmented approach to workforce development.
Yeah, and the marquee programs at the federal level are largely in their loan repayment program. So they allow physicians to essentially have their medical school debt forgiven over time. There's a retention problem that comes with that over time. And doctors will go one place to do their internship and they may go another place to have their loans forgiven, but keeping them there for the long term is a challenge. Some of them stay, some of them don't stay. But those programs, as Marion and Mark pointed out, are not funded to the point where they're going to address the problem. They put a dent in the problem, but they're not.
Thank you. Mrs. Olivares?
Thank you, President Jones. I was going to make comments similar to what Ms. Green and Mr. Molds said. So for those of you who are watching, oshpd.ca.gov has some of those resources online. California State Loan Repayment Program. I often get asked by friends and acquaintances about what resources there are. And as Ms. Green mentioned, those resources are few. And as Mr. Molds mentioned, there is a time commitment on the federal side of 10 years, and it is a challenge to fulfill that. So I believe there's not partial repayment at this time, but that is definitely something that we should look at. And again, information is available online. Thank you.
Thank you, Ms. Olivares. Mr. Miller?
Yeah, I won't comment. I won't go into too much, but when it comes to shortages of medical professionals, whether it's nurses or physicians or other practitioners, I have a real sense that it is a supply problem and it is an artificial shortage that's been created somewhat intentionally over the last 100 or so years, particularly with physicians. But I think, what are your thoughts in terms of that when we see things like, offshore nursing schools being basically sponsored or spun up from scratch with funding from Western countries, including the US, and also even, in this country, more kind of industry-sponsored medical education, including medical campuses being spun up to try to address this, kind of at the root. So I think that's something that, as a longer-term trend, I'd be interested to hear your thoughts on.
I don't have particularly well-informed thoughts about that. I agree with you that there's always an element of supply in this issue. It is the case that in the U.S. we pay physicians more compared to many other professional categories than most comparator countries. That sort of hints that if something's restricting supply or some combination of policy and regulatory decisions allows that, when in other labor markets it does not. But in terms of the actual mechanism for how you address it, and the extent to which those are expanding the size of existing training programs versus building new ones, I really don't know quite enough to comment.
Okay, thank you. Miss Taylor.
Sorry. So, and I think one of the things, there's a lot of stuff that adds to that, but I think we have to think about college has gotten so expensive now that and you go to, what is it, 8 years of medical school? And you're still just a resident?
College, yeah. Mm-hmm.
Yeah. So it seems like that cost prohibition right there is keeping other people of color out. It's keeping anybody that can, would maybe be interested in doing it, but just cannot do that kind of education. So I think that's where another inequity lies, and it was a constructed problem as taxes were pulled away from colleges. So that's I don't know how we fix that. There's all kinds of problems in our healthcare system, but it would make sense to give them incentives. I don't know about that 10-year commitment though. I get a 5-year commitment. So, but a 10-year commitment sounds like something hard to do. And if you're getting enough of these people to come in, then when that person leaves after 5 years, you get another person in. So I don't know how that would work for California. I know federally you're saying it's a 10-year commitment.
Okay. Go ahead.
I was just going to say there has been several of the foundations in California convened this Future of California's Health Workforce Commission that has a set of recommendations across the different types of healthcare providers and the workforce as a whole. So perhaps listeners may want to learn more through that process.
Great, thank you. Okay, seeing no additional questions from board members, I'll go to Mr. Fox and see if we have the speakers would like to comment on this section. And Mr. Fox and Ms. Taylor, would you take the gavel? I'll be right back. Mr. Fox, please.
Got it, Henry.
Yes, Mr. President, we have one caller.
Okay, go ahead.
Okay, our caller is Mr. J.J. Jelensik.
Hello. A couple of things. Slide 31 had no scale, and that's the slide on preventable hospitalizations. I assume the darker the shade, the higher the readmission.
That is
but that's
correct.
An assumption.
That's correct.
Okay. Okay, thank you. And then the other thing that I wanted to ask about is, we've heard over the years that competition is really the key to driving down costs. Yet you said on a per capita basis, there are more primary and specialty providers in the Bay Area than most other parts of the state. Then why are prices so high in the Bay Area?
Are you ready for me to respond?
Yes, go ahead.
Okay. So competition in our healthcare system typically occurs at the health care organization level, so medical groups and hospital systems, which then are in contract with health plans. And so the level of concentration or the level of competition is among those entities. And so you have in the Bay Area, for example, a few very large and powerful medical groups and hospital systems that really influence the prices, and perhaps not coincidentally, can attract providers who want to work for them. And so, again, it may seem counterintuitive, but it actually sort of all adds up in that way.
So the real competition is not really providers as much as it is hospitals and groups.
Correct. Because again, of the third party and large volume contractual relationships that drive spending in our healthcare system.
Thank you.
You got it, Henry?
Okay, yes. Mr. Fox, are there any other requests to speak?
Mr. President, no, that was the only caller.
Okay, thank you. Okay, so now we're going to wrap up our session on healthcare landscape in California. It's been a fascinating discussion so far, and I appreciate the amount of time we've been able to devote to such an important time for members of CalPERS. So now we explore the options to affect lasting change. Ms.